Good evening. Welcome to America's Heroes Group Roundtable live stream digital media show. I'm your host, U.S. Army Combat Medic and Flight Surgeon, Colonel Dr. Damon Arnold, U.S. Army National Guard retired. Today is Friday. Friday is going to be a very special day for us. Today is Wednesday, May 7th, 2005. But on Friday, May 9th, 2025 is Military Spouse Appreciation Day, which recognizes the service and sacrifices of military spouses. So happy Spouses Appreciation Day, and also happy Mother's Day to all of those who are out there who are moms or who take the role of mothership on by helping to mentor others who are younger. America's Heroes Group partners with, Kaiser Family Foundation Health News. Has some really special correspondence, and this is a special article we're going to talk about today. It is authored by Susan Jaffe, and the topic is When Hospitals Ditch Medicare Advantage Plans, Thousands of Members Get to Leave Too. And this was published on April 28, 2025, and I'm one of those people who believes in sources. Go and read the article. Make sure you read her article. It is excellently written. But there are a few questions I discussed with her about this particular topic, and I think they are really germane. So, welcome, Susan, to the program, and this is really a well-written article that you have.
Oh, thank you, Dr. Arnold.
Mm-hmm. Yeah, so we're going to start off with a series of questions, but what is Medicare Advantage, just to set the stage for everyone who's not really familiar with that?
Well, let me just say there are like two flavors of Medicare. There, chocolate, vanilla, strawberry. Regular Medicare, you could call it vanilla, is a government program, and if you're over 65 or if you have some certain disabilities, you are eligible for Medicare. Doesn't matter what your income is, as long as you meet the age requirements. And once you enroll in Medicare, which covers your hospital stays, nursing home stays, any time you need to go into a facility, it also covers, as you know, doctor appointments, tests, X-rays, that sort of thing. But you have a choice of the government-run Medicare program or insurance company-run Medicare Advantage. And Medicare Advantage covers everything that Medicare covers. As I said, hospitals, doctors, drugs, nursing home care if you need it. And Medicare Advantage also offers limited dental, hearing, and vision benefits. And a lot of people are really attracted to Medicare Advantage because insurance companies can offer more benefits than the Medicare, the regular plain old vanilla Medicare. But there are some pluses and minuses with Medicare Advantage, and feel free to interrupt me at any time. This is one of my favorite subjects. I can go on and on.
It sounds like you're really well versed in it. The way you explain it was very clear.
But then the thing is, though, with Medicare Advantage, they offer some extra medical related benefits like dental, hearing, and vision, and then they offer what I call extra supplemental benefits that may or may not be related directly to your health care. It could be a gym membership. It could be a discount on groceries or over-the-counter drugs you would buy in the pharmacy, Advil, aspirin, that sort of thing, allergy medications. They also can offer transportation to doctor's appointments, also some home delivered meals after you get out of the hospital, depending on what plan you sign up with. It could be you get 10 meals after you leave the hospital, as long as you stay a certain amount of time, but it depends on, every plan has different strings attached. And you might get 10 days worth of meals or 5 days worth of meals. You also, I think I mentioned transportation to and from the doctor, but there might be a limited number of trips per year, depending on which plan you choose. And there are lots and lots of plans. I looked up in Cook County, in Chicago, you would have, believe it or not, 63 Medicare Advantage plans to choose from.
Great. Wow.
And throughout the country, there's at least 34 per county across the country.
That's amazing. I had no idea there were that many plans out there.
Yeah, and I mean, the idea is that they're hoping that, people will vote with their feet, and they'll go, a good plan will eventually, attract more customers, just like, a good restaurant gets, you have to make reservations in advance, it has a certain reputation, and eventually the plans that are not so good are supposedly would go out of business, and eventually over time the plans would improve because there's competition for customers. I don't know if that's actually, it may not, it works a little differently in the healthcare field, because unlike a restaurant, everybody is going to need to go to a doctor sooner or later. And
Right.
why don't you?
Yeah, one of the things I was going to ask you too is, like, I've heard this before, where there like things like silver sneaker programs for gyms and gym memberships and all. I'm not sure if that's part of the Advantage, Medicare Advantage plans.
It is.
Oh, it is. Oh, okay.
And I don't think silver sneakers exists anymore, but different plans have special arrangements with different, maybe it's the YMCA, maybe it's some private gym, depending on what city you live in. And again, the gym memberships can vary, and they're limited. You might even be able to get a Pilates class, but only 4 times a month. There may be, and you can only go to the organization that the plan has an agreement with.
Yes. Yeah.
And they actually do the same thing with doctors and hospitals, which is what I ended up writing about. They approach. And I've never been in the room for this, so I'm just imagining how this goes. And I think you may have been in the room, but the plan will say to the hospital, "We've got, I don't know, 3,000 members in Cook County. We will bring those 3,000 patients to you, if say, Mr. Hospital A." If you give us a good deal, and don't charge us too much, and we will guarantee that you have, at least a certain number of patients coming to you, and a contract is reached. And unfortunately, the contract is for a limited amount of time, and it does not correspond with the 12 months in a calendar year that you sign up for a Medicare plan. The Medicare Advantage plan runs from, January through the end of December. But the agreement with the hospital might run from June to June, or may run, for 2 or 3 years, and all of a sudden, if the hospital is unhappy, or the doctor group is unhappy, they're not getting paid on time, there's too much red tape, there's been problems with something called prior authorization, where the doctor or the hospital has to call the plan and say, hi, I have Mrs. Jones. She's coming in for a knee replacement. Is that okay? And will you cover it? And that takes a little while, and it doesn't always go smoothly. And so the hospitals say, you know what, I think, we're going to leave this Medicare Advantage plan. And various companies, I think the top insurance companies in the country that offer Medicare Advantage are United Healthcare, Humana, Aetna, and a couple of others, Blue Cross Blue Shield.
Yeah.
And you could be in one of those plans, and if your hospital is dropping out, it could be the middle of June, and unfortunately, your Humana plan, or let's say the ABC in Medicare Advantage plan, has a contract with this hospital. The hospital leaves, but you are still in the ABC Medicare Advantage plan. You can't leave until December under most circumstances, but your doctor is gone. You can't go to that hospital. If you can go, but you'll have to pay the full price as if you had no insurance at all.
Oh boy, that's not
And
good.
I've spoken to a lot of older people who, number one, they love their doctors, or they love the hospital. It's 5 minutes away. They've been going there for years. They don't want to switch providers. And maybe they have multiple providers. They might have a cardiac condition. They might have arthritis. They might have a need, joint problems. So they have multiple kinds of doctors that are not easily replaced by another hospital or doctors group.
Yeah, so you may actually be in the middle of care too. I mean, if I had a cardiologist that did a workup and they said, well, you need to get, some kind of cardiovascular procedure done, with the, with an endovascular procedure, or, a valve replacement in the heart, aortic stenosis or whatever.
Or cancer.
Or cancer, right? You're in the middle of cancer treatment. And then
there is a provision for that. There's a whole host of rules that Medicare Advantage plans have to cover. And if you are in the middle of serious treatment, you get an extra 90 days to find another doctor.
Ah, okay.
When there's a breakup between the hospital and the insurance company. And I should say that some Medicare Advantage plans have what's called out of network coverage. In other words, the doctors who agree directly with the company that, yes, we'll give you special rates and you'll give us a certain number of patients. Those are in network providers, but there are also out of network providers, and some Medicare Advantage plans will have arrangements with specialists who are not part of the network, but you can still go to them and there'll be an extra charge, but you can still use your insurance card when you go see that doctor, and you won't have to pay the full amount as if you had no insurance at all.
So it sounds like, because there was one of the questions I would have, like I said, is, why does Medicare Advantage restrict members to a network of doctors and hospitals? But I think you're answering the question. It sounds more that it's based on market dynamics and, cost containment, those kinds of things. And
it's all about economics. I mean, you may, this is a crude example, but when you go into a grocery store, they may not have all the brands that you're looking for, right? And there maybe only certain stores will have certain items because they're suppliers and they've made agreements with suppliers
Mm.
or the middlemen or whatever. And so now they have, a variety of products on the shelf, but not all, uh, uh, not every Medicare Advantage plan will have every single hospital and doctor in your county or in the vicinity, adjacent counties, in their network. And as I said, the network can change during the year.
Yeah, that analogy is brilliant. I really like that analogy, with the supermarket comparison. It's sort of like the shopping place of medicine across the country, right? And you're
Yeah. And there's been a lot of debate about whether or not you can use, compare medicine to any other kind of consumer product. And I think, with Medicare Advantage, it is trying to give people choices. Like I said, 63 plans in Cook County, which I don't know, even if it was 63 kinds of crackers, that might make you crazy. You know, how do you? And like I said, some have, limited dental. They might have a cap on how much coverage they might give you. Another plan will only cover cleanings. Another plan will only cover a few cavities. I mean, it's very, very hard to make a apples to apples comparison. I think most people, especially older folks, are, with limited budgets, are really can be pretty good about, hunting for a bargain. And when things are on sale, in one supermarket, you'll go there and then get a sale the next week someplace else. But
Right.
you can't always do that kind of comparisons and comparison shop when it comes to healthcare and hospitals, even if you're in traditional Medicare, which has no network, you still might not choose the cheapest um, colonoscopy, for example.
Right. Right.
You may not have time to shop around. Certainly with nursing homes, um, most people, in order to go into a nursing home, as you know, you have to have a doctor's order, somebody saying, you need 24-hour care. And depending on the, insurance company, your charges might vary from nursing home to nursing home, I think. After you use up the minimum number of days you are allotted for nursing home care.
Yeah, and what you're saying really explains why, providers can leave the network, or an institution, a hospital or clinic can leave the network during the year because of the economic considerations, probably the contractual relationship or agreements. And then, the beneficiary usually has to wait to the end of the year. But there are some circumstances, I guess they can, that under those circumstances you were mentioning, like the 90-day extension, those kinds of things for people who are, under care right now, that sort of serves to protect them to some degree.
Yeah, and then you can also get what's called a special enrollment period.
Okay.
And there are about 15 or 16 kinds of special enrollment periods, which means if your Medicare plan goes out of business and it's only June, obviously it's not your fault. So you need an opportunity to enroll in a different plan. And when that happens, the Centers for Medicare and Medicaid Services, which runs Medicare, the government-run Medicare, and it oversees, it's the sort of the policeman on the beat for Medicare Advantage, making sure that Medicare Advantage is following all these rules. So if the plan goes out of business, the CMS is the acronym. CMS will say, okay, everybody in this who's now, who lost this plan, it went out of business, you can get a special enrollment period to sign up for a different plan.
Okay.
They recently, a couple of years ago, they added another kind of special enrollment period for people who are losing their doctors or hospitals because they can't reach an agreement on a contract.
Okay. Okay.
And sometimes, like the gentleman I wrote about who lives in Dallas, he lost his plan, but he lost it at the end of December 31st. And luckily, he was able to go into a different plan and keep his hospital. So one plan ended, the new plan started the next day. So no interruption. But if that and that's because at the every year in the fall, you have an opportunity to switch plans, and the new plan will always start January 1. But if you're in the middle of the year and you lose your hospital, you can request a special enrollment period.
Yeah, but you're bringing up a point that's really important.
It's up to you, though. I mean, there's two kinds of these. Tell me if I'm getting a little bit too much in the weeds. I've been accused of that.
Oh, no, this is fine. Doing great.
But there's when you lose your provider, there's two kinds of. There's a special enrollment period that the individual can request, and CMS will grant it on an individual case-by-case basis. And very few people know about this, and you have to contact 800 Medicare. That's the toll-free number for the Medicare program, and you have to request it. But sometimes there are thousands, I've discovered, hundreds or thousands of people who go to a hospital, especially when the hospital has 52 different facilities in multiple counties, a big hospital system. And if they leave your plan, you have hundreds of people in the middle of the year who either have to give up their doctor who they've been seeing for years, or they have to get permission to switch plans. And it's gotten this phenomena of, divorces between hospitals and insurance plans have become so common that people have complained to their Congress members. In the case of Maine, where the Congress members in Maine, both senators and Congress people, contacted CMS and said, we want a special enrollment period for these people who are losing their hospital. And CMS said yes.
No, great.
Because the Medicare Advantage plan has to have enough doctors to meet and hospitals and other kinds of facilities to meet the needs of their members. That's what insurance is for.
Right.
When you get sick, but if you don't have enough hospitals or you don't, then you can't serve your members. And in these cases, like in the state of Maine, for example, they were able to get a special enrollment period for a whole group of people. And the individual members didn't have to go through a lot of hoops. They were offered the opportunity to leave the plan and pick another one and stay with their doctor. And that's happened in Maine, in Delaware, in Minnesota. I'm looking at my article now. Parts of South Dakota, all over the country.
Yes.
It's been happening, and a lot of people don't know that they have this opportunity to get what's called a special enrollment period based on a change in the provider network.
Yeah, that's extremely important, because I think most people, when they choose their plans, they choose a plan where they have, reasonable access as far as time and distance, from where they're living. And, if they are busy with family matters or, just the regular things you go through in life when you're working, or even if you're retired, you may be more restricted in your mobility. And they try to get a place that's pretty close to them. And you were making me think about, the differences between urban and rural. There must be some differences there as well.
Oh, sure.
Yeah.
And the other thing that the Medicare program, when they're supervising these Medicare Advantage plans, they do say that you have to have a certain number of hospitals, a certain number of doctors within a certain maximum time and distance from the patient.
Yes.
And sometimes a hospital will drop out and CMS will say, that's okay. We don't need to give you a special enrollment period. You have plenty of other choices.
Okay. Yeah.
And I would say that people should call their what's called a SHIP program to get for more information. It's the Senior Insurance Information Program.
Okay, great. Well, we're running out of time, but it's really a massive problem, because you were mentioning about 54% of the 61.2 million people with both Medicare Parts A and B were eligible to sign up for Medicare Advantage in 2024. I really encourage people to read your article. I think it was really well written and very informative. And how can people get to your website to see your article?
Go to kffhealthnews.org.
Okay. Thank you so much. Thank you so much. We're looking to have you back on, Susan Jaffe, a great reporter, and thank you for elucidating all this for our viewing audience.
Right. Thanks for calling attention to this issue.
All right, thank you. Take care.
Okay.
Where voices, information, and resources are empowered intentionally. Market, advertise, and sponsor your business with Vietnam veteran Cliff Kelly and America's Heroes Group, where information and resources are intentionally disseminated via radio, print, and social media. Call our office for more details at 312-803-2618.
I'm Ken Jennings. All of us here at Jeopardy want to thank you for your service to our nation. We truly honor and appreciate you, and what's more, we're looking for contestants like you to play on our show. So head to Jeopardy.com now and take the Anytime test, and we're looking forward to seeing you soon right here on the Alex Trebek stage.
Intentionally.
Stream Digital Media Show. I'm your host, U.S. Army Iraqi Combat Medic and Flight Surgeon Colonel Dr. Damon Arnold, U.S. Army National Guard retired. Today, we have a couple of extremely special guests. Friday, June 9th, 2025 is Military Spouse Appreciation Day, which recognizes the service and sacrifices of military spouses. We all on this call will have spouses that we are making sure we send our love out to for their help in our lives. Also, happy Mother's Day from America's Heroes Group. The guest speakers, we have an incoming VFW National Commander, Carol Whitmore. Carol Whitmore was elected Senior Vice Commander-in-Chief of the Veterans of Foreign Wars of the United States on August 1st, 2024. She served in the U.S. Army for 36 years, from 1977 to 2013. An Iraq War combat veteran, Carol, among many other military medals and awards, received the Legion of Merit Medal, a Bronze Star Medal, and six Army Commendation Medals. She joined the VFW in 2012 at Post 9127 in Des Moines, Iowa, where she maintains her Gold Legacy Life membership. Carol attended the University of Northern Iowa and Hawkeye Community College. She is a retired nurse. In 2022, she was elected as designee for the National VFW Commander-in-Chief for the year 2025, becoming the first woman and first Iowan to hold the position. Along with her, we have the incoming Illinois VFW Commander, Eugene Blackwell. Colonel Eugene Blackwell retired in 2014 after 30 years of service in the Army National Guard and Reserve, after serving in various capacities, including platoon commander, battalion detachment commander, health and dental clinic commander, and battalion commander. He served in Operation Enduring Freedom in Afghanistan from December 2008 to September 2009. Eugene worked for over 30 years as a registered pharmacist with the Department of Veterans Affairs. He is a member and past president of Alpha Phi Alpha Fraternity Incorporated, Theta Mu Lambda chapter, which he brings up in many different meetings, and currently chairs the Theta Mu Lambda Charitable Foundation. He was elected as a senior vice commander during the 2004 VFW Illinois State Convention and will assume the office of Illinois State VFW Commander in June 2025. The topic for today is really the vision that the two of these incredible individuals have in respective roles, Carol on the national level and Eugene on the state level for Illinois. The VFW mission is to foster camaraderie among United States veterans of overseas conflicts, to serve our veterans, the military, and our communities, to advocate on behalf of all veterans. So with that, I'm going to bring Carol to the forefront. And Carol, welcome to the show, and congratulations on the new position. And this tells us a little bit about the new position and what this means to you.
Well, it will not happen until August of in a couple of months, actually. Okay, yes. It is still an elected position, so I still am at the mercy of the membership, to do this. But knock on wood, that will be happening for myself. But it is a pleasure to be back here again. I was on here in December. Yes. When I was actually out at Pearl Harbor recognition in Hawaii. And so I was very, very honored to be on at that time and again this time also. So thank you.
Thank you. Okay, Colonel Blackwell, you have any opening remarks?
Oh, no, I just want to say that since I retired from the government in February, it seems like I haven't been retired because I've been doing a lot of work with the VFW. Just last night, I was attending the Stoll ceremony for the Prairie State College, and I was the guest speaker.
Oh, yes. Yeah, and when you retire, everyone sees that word and they say, "Oh, it's an available worker."
Yes, exactly.
Very careful.
I've been learning that.
It never ends, Gene.
No, it doesn't. I see.
So, Carol, tell me a little bit more about, the national landscape and what you envision for the VFW. What are some of the concerns that, the members of the VFW are contending with right now? What are your wishes for them as, veterans of foreign wars that, actually built this nation, protected it, and still serve it?
Thank you, Dr. Arnold. The veterans of foreign wars have been on a mission since 1899, and the mission never ends. And we have to make sure that we take care of every veteran, and especially, my passion is for the veterans of foreign wars, but every veteran demands and deserves to be taken care of. And one of our biggest goals and priorities for the next coming year is to make sure that the government honors the contract that we signed, that you signed also, and said you will defend the United States. And so we fulfilled our contract, and now we're asking the government to fulfill their end of the bargain. When we signed on the dotted line, we said, we will do this, and we expect them to hold up their end of the bargain, of the contract. And, another thing that we're doing is cracking down on unaccredited claim consultants. And we've affectionately called them claim sharks. And because they, take advantage of fellow veterans and, promise them the world and promise them 100% disability. And these are desperate veterans. They're looking for money. They're looking for some kind of reprieve for their health. And it's very unfortunate that there's a lot of law firms out there that make those promises, and then they take a percentage of that veteran's pension and disability for the rest of their life, upwards of 45%. And it's shameful. And we're not trying to take away every law firm. There is a place for law firms, but we want to make sure that they're accredited, just like we provide a free service with our veteran service officers with the VFW. We do it for free. We will never charge, and we will work tirelessly to make sure that the veteran is taken care of properly.
Yeah, that is so critical. I mean, it is just unconscionable that you would take, it's like, you get to the point where you start wondering, what kind of person would do that to a veteran that is actually supporting this country. It takes a really despicable kind of person to do something like that.
It does.
It's just the moral conscience has to be absolutely abysmal, and has no place being on the stage at all, taking care of veterans. So Eugene, what if you have been piling up dust on your vehicle, and I know you're getting another state vehicle coming down the road. I've seen you go through stages of one district to the next, and it's like a ping pong ball across the state. But that's really great. I mean, what motivates you to do that?
What motivates me is that it tends to be a continuation of what I was doing when I was in the service. Talk with my soldiers, fellowshipping with them. We have a mission to perform, to see how the mission is going, and to see what kind of resources that they need to fulfill that mission. So it seems like that work never ends. And, like I was telling the veteran students last night, please don't let this education for you being in, there's always a lot of other work that needs to be done to advocate for our veterans, working within the community and making sure that each one of us, are doing well within ourselves as veterans.
Yeah. Well, Senior Vice Commander, National Senior Vice Commander, Carol Whitmore, Colonel Blackwell bought a ticket for me for the 50-50 split, and actually it won. So I'm trying to get him to do the Queen of Hearts for me, but he won't do that.
Good for you.
In the mix, so.
Good for you. I know the Queen of Hearts. I've been in Illinois, and it's a very profitable gaming type thing. And I know at one point it was even bet on in Las Vegas, when it was going to go out and how much it was going to be. And it's quite a profitable little business for Illinois. And I applaud them for that, because they make it work. And
Yes.
Eugene has a passion for the VFW and a passion for fellow veterans. And I'm truly grateful to have him as part of the VFW team.
Oh, great. Yeah, one of the things that you mentioned earlier was this issue about, all veterans. And, sometimes we joke with each other from different branches. I know you're Army, and that was 36 years of Army. But, the other branches, the Marines, the Navy, the Air Force, the Coast Guard, now we have the Space Force. All of those are really becoming more and more, they've always been important in our in the mix of what we do as a military, with the Space Force being more of a recent addition. But, how important is it for us to work as a team, when we are in the VFW status?
It's critical. It's not just branches. Whether or not you served overseas in a hostile environment or in a combat situation, the VFW will take care of anyone, whether you're VFW eligible or not. If you're filing a claim for disability, we will take care of you. And that is our creed and our motto. It's just like the military. You leave no one behind, and we will not leave anyone behind that deserves that kind of care.
Yes, and one of the things that we really have in the background too is that we have a lot of younger soldiers and service members, I should say, men and women who were in combat regions who came back, and that they need to know that this is an organization that will support them, right?
Yes, absolutely. Absolutely. Whether or not you served on foreign soil or not, if you're filing a claim, we want everyone to know that served honorably in the military, we will take care of them and we will file their claim for them.
Yes.
That's what we do. We take care of each other, because we all know the government will not knock on our door in 10 years and ask us how we're doing. But we will. The VFW will.
You can knock on the door as well. Yeah, and that's important for them to know, is that the actual undergirding of democracy. There are three basic pillars. Freedom of speech, and then we have the ability to have free and fair elections, and then we have the ability to take care of people who are in need within the country, who are suffering from poverty or whatever that's going on. But this overarching thing about having an intact judiciary over it, all those things depend on the military being strong and being able to support a democracy. And so I think they have to realize that who they're talking to are people who actually raise their hand to defend the Constitution and their very jobs as legislators.
Yeah.
So hopefully, they're listening more and more to the needs of veterans as time goes on. When is the convention for the VFW, the national convention? That's in August, I think you were mentioning.
It is in August. It is the first week of August, and that's when I should be taking over. And then Eugene will be off and running for the state of Illinois to take care of them, and as well as the rest of the United States. We have 52 commanders that will be taking part in this, and I have such an incredible team. They are all warriors, and they have all proven themselves. They deserve to be where they are in command of their states, and I'm very proud to serve alongside them.
Yeah. What does it mean to you? This is something we don't talk as much about, even though we all experience it. Like if I go to my VFW post 311 here, Benjamin O. Davis post, there's a certain amount of camaraderie, because we always use the, comrade as a term, but camaraderie. Mm-hmm. And what does that mean to you? Because when I go there, I feel like I'm stepping into another dimension, and I feel like I'm back at home.
Yes, it's an unexplainable bond that the military people have, and we can kind of pick on the other branches, the Air Force or whatever, but no civilian can do that. We will go to battle for them. There is no other bond like a military bond, and stepping into a VFW, we're trying to change that perception of the smoky old bar. It's much more than that now, and we are out in our communities, providing services, cleanup, providing rides for people. It is not just about a smoky bar anymore. We are trying to change that perception, and that that was the way it used to be, but it's not anymore.
That's right. Yeah. So Colonel Blackwell. So as you're looking forward to doing things in Illinois, what are some of the things you think are needed for veterans in Illinois? Are there certain things that you feel are more important to focus on right now?
Yeah, well, my focus is mainly going to be working within the community, and how the different generations intermingle with each other. As you know, we got the baby boomers, which kind of like VFW, but they have to learn the values and the characteristics of the other generations, like the Generation X, Generation Y, because they're going to be our future. And you're not going to have an organization unless you have younger individuals, being guided and taking the role of leadership, so that you can sustain, your organization. Because I know in Illinois, we've got a lot of posts that are closing, and we have to identify, who these posts are, what it's going to take for us to have younger individuals, younger veterans come in, and take over the leadership positions within that post. And that's going to be a challenge for us.
Yeah. Yeah. Because, one of the things I run across many times is like, that one of my favorite places to eat, and Eugene knows this, is the Cracker Barrel.
Yes,
right in Henley Park. And I go in there, and sometimes I'll run across veterans who are in there, and they actually have their paraphernalia, that combat hats and things, and Vietnam. And then I'll mention to them about the VFW, and some of them are like, "Oh, really? I could join." So and maybe it's reaching out to people and doing that person-to-person thing. And that's something that I think is going to be critical in trying to garner that membership. And the younger people too, that the intergenerational bridge, we do have to cross it, as you were mentioning. I think that's important. But what about the homelessness of veterans right now? Is that something that, is a focus as well, or how do we contend with that?
It's always a focus, and very sadly, every state experiences that. And that was a special project of mine when I was a state commander for Iowa. And it will always be there. Some choose to be homeless. They don't want to be back in society. I think that's a smaller percentage, but it will always be there, because people struggle when they come home, and they don't know how to come home. We teach them how to go to war, but we don't teach them how to come home. And we need to do a better job of that, and a better job for advocating for those on active duty, to make sure that they have the benefits that they need. They have the education to come back home when they either get out or retire, because that's how they're going to benefit their communities and you know, be part of that community and feel like they are part of that family again. That is a struggle. It always will be, but we're working to change that.
Yeah, because one of the things I try to do is to really support, you know, veterans businesses or veteran-owned businesses or businesses that support veterans. You know, they give discounts. You know, like Home Depot, for example, or that's many different businesses. But I try to make sure I do my business with them because it shows that they care and they're appreciating the need among families. One of the things that really was heart-wrenching to me, I came back from my second tour in Iraq, and after the second tour, I learned about one veteran who was in Southern Illinois, had lost both of his legs and his right arm. He was a farmer, and his wife was working 3 jobs, trying to keep everything afloat. And I couldn't understand, I couldn't even comprehend what was going on in his mind. And, you know, we had this whole issue about suicide rates and all that. And that's the only thing I could think of was this guy is being pushed to the edge. And
yes.
So, you know, this whole thing with the suicide rate also, you know, among our veterans, you know, the mental health care concerns seem to be need to have more investigation, more resources, and really push them a little bit more.
Absolutely. You know, that's always on our minds also. You know, we have a contingency that we're trying to take care of PTSD in a different way also, have alternative medications. And we are partnering with a group called Grunt Style, and they have been in the forefront as far as advocating for different and alternative methods to take care of PTSD instead of just throwing another pill at somebody, because that doesn't solve anything. You know, you're not taking care of the root problem. All you're doing is masking it with, you know, either a painkiller or something else. It goes much deeper than that, and that's where we need to really take care of our fellow veterans.
Yeah, and then, you know, medical background, I really love it because you have more insight into that. You know, understanding what the playing field is really in the healthcare arena, which is extremely important right now for our veterans, and you know, to educate them and make sure they're aware of some of the healthcare concerns they should have. So you know, Colonel Blackwell, what I'm going to do is I'm going to start with you, then I'm going to come to Carol. The question is, you know, can you relate you know, a good story that you had in the military, one of your favorite stories about your service?
Do you really want to know? Well, I won't bring up that one.
That's what I figured.
I don't want to bring up that one. Well, I can tell you, and like I told the group last night, the first time that I've been out the country and even on a plane was on a medical exercise to Bolivia. Huh. Now, you know, back in the 90s, Bolivia had the world's highest infant mortality rate, right? And so they send National Guard units or reserve units down there to do, you know, medical support. So we go down there as a unit. I was not in command of the unit. Actually, that's my first one. I was a second lieutenant at the time. And we go through these different villages and, you know, we give them medical support. One of the first things that we give them, especially the children, is we deworm them. We don't deworm the adults because you deworm the adults, they're going to keep drinking the water there. And so they're going to get the worm again. So we just decided to do the children. But we try to meet their needs. But what it made me do is it made me appreciate the country that I come from, because I see how third world countries live. Mm-hmm. And I see why the need that we pay taxes.
Yeah.
Like those. I can relate to that, yes. Eugene.
And as you remember, they were taking the boxes from our MREs and using them in their kitchen for pantries.
Yep. Yes.
Well,
Yeah.
that was my first.
I have a similar story.
Yeah.
When I was stationed in Guatemala for 6 months,
Oh yeah.
one of my favorite things was one of my younger medics at the time took out one of our ambulances and had an accident with it, and it was quite the circus trying to translate, who was at fault. And she basically wrecked my ambulance, and so we had quite a time with that. But Guatemala was I probably somewhat similar to Bolivia. It's a third world country. They appreciate anything that they get, and we built a clinic there for them, roads, and it's absolute military rule in those countries. They have no other recourse, and it does make you appreciate living in the United States much more.
I was there 4 times to Guatemala. The last time I was there, I don't know if you remember Ford. He asked me to come, and I came mostly as an advisor. But what I did was I kind of decentralized everything. Instead of doing it the old-fashioned way, where the people in Guatemala come in, they see the doctor, and then they get a prescription to take to the pharmacy, where I destroyed all of that. I had the pharmacy, the techs, and everybody in one room. So as soon as the doctor see the patient grabs, what they need as far as their medication, they go right on out. And so we did like 4 and 5 times the numbers that other units have done when they were down there. And it got word to the Southcom commander, which at that time was General Cradock. I said, well, I got to go down there and see what they're doing. So he came down there and he was talking with Ford. Ford said, no, sir, it's not me. It's Colonel. I was Major at the time. It was Major Blackwell at the time. So he gave me a 4-star coin. I said, wow. I was trying to say behind the scenes. But I decentralized everything. So that was another moment.
Yes. Okay, I can hear the music in the background, unfortunately.
Oh, wow.
I wish we could do it on for an hour. I'm not sure there are a lot of other stories in there.
Yes.
Well, thank you so much.
Yeah,
thank you so much.
Thank you.
Welcome to AHG Connects, where voices, information, and resources are empowered intentionally. Market, advertise, and sponsor your business with Vietnam veteran Cliff Kelly and America's Heroes Group, where information and resources are intentionally disseminated via radio, print, and social media. Call our office for more details at 312-803-2618.
Ken Jennings. All of us here at Jeopardy want to thank you for your service to our nation. We truly honor and appreciate you, and what's more, we're looking for contestants like you to play on our show. So head to Jeopardy.com now and take the Anytime test, and we're looking forward to seeing you soon right here on the Alex Trebek stage.
Intentionally. Where voices, information, and
Good evening. Welcome to America's Heroes Group Roundtable live stream digital media show. I'm your host, U.S. Army Combat Medic and Flight Surgeon Colonel Dr. Damon Arnold, U.S. Army National Guard retired. Friday, May 9th, 2025 is Military Spouse Appreciation Day, which recognizes the service and sacrifices of military spouses and family members. So make sure that you reach out to them and thank them. Today, I am, the president and CEO of the African Diaspora Association of Public Health Professionals, LLC. But that is part of my public health background. Today, I wanted to present to you an overview of current health status in the United States of America and some of the things that we're confronting as far as health is concerned. Now, the World Health Organization definition of social determinants of health is the conditions in which people are born, grow, live, work, and age. This includes factors such as income and social status, employment and working conditions, in education and literacy, and childhood experience, such as the ACEs study showed, the adverse childhood experiences that many people speak about. But it also includes physical environment considerations such as infrastructure adequacy, pollution, and climate change impacts, as well as social support systems and coping skills. Participation in healthy environments requires certain things to be present. So healthy behaviors, access to healthcare services, biology and genetic endowment, gender, culture, and race are additional factors that play a role in this. In a world that is constantly changing, these factors and circumstances are shaped by the distribution of money, power, information, and resources at global, national, state, and local levels. So our world economy and how things flow with a world that now is not separated by months or years of travel, but by hours and sometimes even minutes of travel to get from one location to another, has a dramatic impact on how we interact as a global society. The United States in 2005 healthcare projections indicated that continued increases in medical costs, out-of-pocket expenses, and insurance premiums will occur. A rise is also expected in the prevalence of chronic conditions such as obesity, diabetes, and heart disease, really mainly focused on some of the healthcare and practices that we have, our health behaviors and how we eat foods and how we support ourselves as far as mental and physical health. But the Affordable Care Act insurance premium subsidies, now capped at about 8.5% of income, are set to expire at the end of 2025. If they're not renewed, the cost will double. The fear is that individuals may opt out or delay skipping vitally necessary medical care, leading to poor health outcomes. It is important to have strong consumer protections in such a healthcare arena. At the same time, the current administration has correctly pointed out that ultra-processed foods represent nearly 70% of American diets and is linked to obesity and multiple other chronic diseases and cancer. The current Trump administration has noted a need for a change in the American diet in order to avoid the onset of chronic disease in the general population. This in itself actually has implications for the onset of chronic disease and averting chronic diseases. This actually leads to why we have such high medical care costs in this country. A lot of it has to do with the kind of health we are subjecting ourselves to by the things we eat, by the air we breathe, and by many of our habits that we should consider: smoking, drinking excessive amounts of alcohol, and such. But our current dietary practices is an area of concern in which potentially monumental steps can be made to make America healthy again. The banning of potentially harmful food dyes and additives is now under active consideration by the current administration at HHS, Health and Human Services. That is a very, very important step for us to take as a nation to make sure that we are focusing on what we put in our mouths. I've said this many times before. Science never asks for you to believe in it, but it is incredibly unforgiving if you choose not to. So the outcomes of what can happen to you if you walk to the edge of a cliff and decide not to believe in gravity can be devastating should you step off the edge of the cliff. So science goes on unrelenting. It doesn't care about our personal opinions. It is actually based on valid or invalid concurrences or conclusions from scientific data. So it's important for us to really focus on this and realize that this is an opportunity as the administration is taking the reign to make sure we address those public health needs concerning food consumption, as Robert F. Kennedy Jr. Has put forward as a major concern for the country. We also have mental health concerns, including rising levels of anxiety and depression, which are now expected more than actually looked upon as being something that is receding. We are actually increasing the number of these instances. This will not only have impacts on those seeking mental health care, but services, but also the stability of familial and caregiver relationships and the mental health care system infrastructure as well. We are lacking providers. We need many more healthcare workers in the mental health arena. And this is something that we are experiencing the consequences of nationally, with violence, with all the things that go along with abnormal behaviors as far as the way that we're interacting with what we eat, smoking, drinking, those kinds of things, which actually cause more damage to our health. The healthcare workforce is facing shortages as well, including physicians and nurses in this arena. There are dire healthcare provider shortages, including doctors, nurses, public health workers, community workers, and health educators, which has been projected by the Health Resources and Services Administration, or HRSA, which is part of the Department of Health and Human Services. This will strain the healthcare delivery system and detrimentally impact access to medical care. It's important that we actually advise people to go into areas like STEAM, science, technology, engineering, arts, and mathematics. Those are the areas that we need to have more people trained in, microchip development, those kinds of things that are part of the AI future. The service industry is also really a key element of our progress as a nation. And the service industry actually represents the majority of the jobs and the income that is provided to this country. So the field of medicine has made remarkable advances, yet some infectious diseases, chronic medical conditions, and healthcare access issues remain persistent public health concerns. For example, parents who kept children up to date with recommended vaccinations dropped from 90% in 2021 to just 82% by 2025. This is below the level required for herd immunity. This has implications for the spread of disease throughout the country. So, for example, measles was officially declared as eliminated in the United States in the year 2000 due to effective measles vaccination programs. However, measles is now threatening to become endemic once again. Projection models in the JAMA report are dire concerning the consequences of such a recurrence based on the current trend in 2025. In 2024, 1 out of 6 parents delayed or skipped vaccines altogether for their children. The Center for Disease Control and Prevention recommends that children receive 2 doses of the measles, mumps, rubella, or MMR vaccine, which includes measles, mumps, and rubella, the first at 12 to 15 months, and the second between 4 and 6 years. Generally, after receiving 2 doses of the MMR vaccine, you're considered to have lifelong protection against measles. 1 dose of the MMR vaccine is 93% effective, and 2 doses are 97% effective at preventing you from developing measles. So your body actually has armor. It can actually respond to the virus should you come across it. and you don't know when you'll come across it. It could be in a supermarket. It could be in a school. It could be in a restaurant. So those places that you're talking about, those places that you come across it, you don't see the virus. It is invisible to you. So getting the vaccination actually protects you without you having to have concern about where you're walking as far as measles is concerned. However, some exceptions exist. For example, if you were born before 1957, the vaccine wasn't available. If you were vaccinated before 1968 with an inactivated measles vaccine, that may be less effective than what we have now. Also, if you are immunocompromised, you have HIV disease, or you have other diseases that decrease your immunity, like diabetes or heart failure, you may require an additional dose, which you should discuss with your medical provider in greater detail. Vitamin A does not prevent measles. A link between autism and vaccines has been scientifically disproven. Again, a link does not exist based on multiple well-designed studies that a link exists between the vaccines and the onset of autism. Does not happen. So PCR, or polymerase chain reaction testing of throat and nasopharyngeal swabs. So these are from the nose and the back of the throat. When you have them put the swab there, can be used to diagnose a case of measles. There have been over 935 cases to date reported throughout the 25 states, most cases occurring in Texas. The vast majority of cases are occurring in unvaccinated individuals. About 13% of those infected with measles have been hospitalized, according to the CDC, with 3 reported deaths. 2 of the deaths occurred in children who had no other underlying medical conditions. They were just normal children living their life, and they ended up getting measles because they were unvaccinated. This is really a tragic situation. My deepest condolences go out to those families affected by this tragic outcome. At America's Heroes Group, we try to do our best to inform the public and make sure that you are aware of some of the things that can actually impact your life circumstances very deeply and result in the loss of life. So make sure that you work with your healthcare providers and consider these vaccinations as a very serious defense against tragic outcomes for you and your family. With the dissolution of the U.S. Agency for International Development's Global Operations, or USAID, and basic sciences research at multiple institutions, there are additional concerns regarding infectious disease surveillance and prevention that we will be confronting as a nation. Priorities in public health for the 2025 include rebuilding trust in healthcare and science, advancing universal healthcare coverage, and closing the primary care gap. Many people have problems with access to healthcare, especially in our rural communities. Many of the major cities have very well-developed healthcare systems, hospital systems, and clinics, and have access through transportation for people who need to gain access to healthcare provision. Although there are areas, even within urban areas, where there is a very distinct barrier to people actually accessing healthcare. We also have many of the veterans who are homeless, who are on the street. Many of them are on the street, sometimes even with family members with children. This is unconscionable. We should be doing something to make sure that we do everything we can to protect these veterans and their families. We have Gold Star families, we have Blue Star families. We have veterans who have been impacted by the wounds of war, lost limbs, had traumatic brain injuries, and such. It's unconscionable for us to stand here and not do anything to protect them. A health commissioner in any state plays a pivotal role in safeguarding public health by overseeing the development and implementation of policies, programs, and regulations aimed at promoting community well-being. This actually works with the legislative process within a state so that rules that are promulgated can be analyzed, look at the efficacy of what they are saying they can do, and then also having the data to back up their impact. So this is something that is extremely important in every state and needs to be supported. This process is critical for the very survival of people. A study released by the Harvard T.H. Chan School of Public Health on March 8, 2023, noted that nearly 50% of all employees in state and local public health agencies in the United States left their jobs between 2017 and 2021. This had a little bit of an overlap with the advent of the COVID-19 pandemic, which was a global scourge. The United States actually did better than many other countries as far as reestablishing its financial base and trying to bring things back to normalcy. But the study also projected that if such workforce contractions were to continue, more than 100,000 public health staff could leave their jobs by the year 2025. Well, they were correct in the trajectory of their projections in that we would have an increase in such losses. However, although understated in the losses of the public health workforce, so we had more people being lost than the 100,000 that were projected, and we continue to lose more as we're going into the future. One of the things that I also wanted to stress is that, we have a legislative, executive, and judicial branch of the government, but the U.S. Department of Homeland Security, the Department of Health and Human Services, the Department of Defense, the Department of Energy, also our Department of State, and the Department of the Interior. These are really important United States departments. The Department of Labor, the Department of Education, Department of Commerce, the Department of Veterans Affairs, the United States Department of Transportation, and the Department of Justice, the United States Department of Agriculture, and the Department of the Treasury, and Department of Housing. These are the major agencies within our country that have some delegated authority from the executive branch and then have oversight by the legislative and judicial branch as well, and the executive branch. It's important to stress that these people who have been working in these capacities have actually helped us to build a great nation. And we must stress that they are, essential roles in our environment. When we start talking about the natural disaster platform, we have this also in many of our interactions with the environment, where we are seeing storms and things that are occurring in tornadoes and hurricanes and all those things. It's really essential that we come together as people and support our government, that we come together to support each other. This actually happens, they say all disasters start locally, and we have things from the federal to the regional, state, territorial, tribal, and local levels that are all involved in how we interact with our neighbors, how we respond to our state, our government, our nation. And so it's important for us to realize that with our communities, we have to be involved in the process of making sure we provide the lifelines and the resources within our communities and the capabilities to enable people to take care of themselves when we face disasters that are coming. So it's important for us to save lives, property, and the environment in all the things that we're doing. So I encourage you to learn a little bit more about this and more about the people who are in your local communities, so that you can actually become more engaged in these activities. Our veterans who are out there are a great resource. So I implore, potential people who are hiring or training programs to incorporate more veterans into your activities. We have so many veterans who sometimes have fallen in bad luck. Some are unemployed who are on the streets, or people who are actually losing their jobs right now in the reorganization of government. But make sure there's a special place for them. They have skills and talents that will be incredibly important for you to include and bring into the fold of your institution, your government job, or your private sector job, your academic institution, your company that makes widgets, right? These people have skills and talents that they have developed over many decades of service to this nation, and should have the ability to come forward and have a place, an opportunity within the nation they help to defend. So as we're going forward, I implore you to take care of your health, to make sure you can start considering things such as having a healthy diet. There are many, many resources that are out there for you to go to make sure that you're not contributing to any degree of poor health. Now, there are different programs for those of you who are retired, who are on Medicare, or even on Medicaid. There's certain programs. There's a Medicare Advantage program that I had discussed earlier with one of the talented people at the Kaiser Family Foundation. They are a company that actually looks at, they're a not-profit organization that looks at medical data and actually do a very good analysis of what's going on in the country as far as health concerns go. And so as they're doing that, they produce information that I implore you to read and to look at. Also to do your own research. If you're eating a diet that is causing high cholesterol, heart disease, those kinds of things, many of the programs now that we have are based on heart disease reversal. So after someone has had a heart attack, they will then go to the point of saying, oh, maybe this person could benefit from not eating certain foods that will clog their arteries further, right? After we've put a stent into the heart. I had one particular veteran who approached me that said, I'm having a little bit of pain in my chest. And I said, well, how long has that been going on? And they said, oh, it's just the last few days. I said, few days? And they said, well, should I go to see my doctor in a month or so? And I said, no, you should get into my car and we're going right to the emergency room. And that person actually was on the verge of having a heart attack. They ended up putting a stent in. So this actually could save someone's life. The only reason why I tell this story is because there are people around you that you need to talk to. Your family members. And if it's you that's having these symptoms, you need to talk to somebody. You don't need to go to the far extreme of having a heart attack or a stroke or kidney failure or being hospitalized for a reason or a condition that could have been prevented had you come forward and spoken to someone earlier. They say God made us with 2 ears and 1 mouth. So when you are talking to someone, listen to what they're saying. If they're telling you, I'm having chest pain, I'm having, pain with, with walking, or I have severe back pain, listen to people and try to assist them. Make sure that they are cognizant of the consequences of what can happen. You don't have to be a medical expert, or you don't have to be, go to school for 12 years to get a medical degree and, go through a residency to be able to understand that these are the signs of a stroke, the fast, right? So, you can have, facial weakness, asymmetry of the facial musculature, right? Or you can have, this weakness in an extremity, so, and then you need to call 911 when you're starting to have these signs of a stroke, because time is really your enemy if you defile it and don't pay attention. So as you're having different symptoms of different medical conditions, it's important for you to come forward and make sure you seek medical care in a timely manner. I'm just saying this to you, and I thought it was important to talk about this because we're moving into a time frame when we are having a lot of medical advances and all of those things, but those medical advances mean nothing if you don't seek medical care for yourself and your family. And you don't protect yourself by getting vaccinated, by going in for a checkup, by getting a colonoscopy, by getting a heart check, and the regular routine blood chemistries, so that you can make sure that you're around to protect yourself and your family. Thank you very much for listening to me, and I hope this was of benefit to you.
Where voices, information, and resources are empowered intentionally. Market, advertise, and sponsor your business with Vietnam veteran Cliff Kelly and America's Heroes Group, where information and resources are intentionally disseminated via radio, print, and social media. Call our office for more details at 312-803-2618.
I'm Ken Jennings. All of us here at Jeopardy want to thank you for your service to our nation. We truly honor and appreciate you, and what's more, we're looking for contestants like you to play on our show. So head to Jeopardy.com now and take the Anytime test, and we're looking forward to seeing you soon right here on the Alex Trebek stage.
Intentionally.
Good evening. Welcome to America's Heroes Group Roundtable live stream digital media show. I'm your host, U.S. Army Combat Medic and Flight Surgeon Colonel Dr. Damon Arnold, U.S. Army National Guard retired. I want to advise you Friday, May 9th is Military Spouse Appreciation Day, which recognizes the service and sacrifices of military spouses. Many of them actually help to defend the nation by supporting the service member that is serving. And also, happy Mother's Day to all of those who are out there. Whether you have your own child as a mother, or whether you take care of people, advise young people as a motherly figure, we congratulate you and really appreciate your service. Our special guest speaker is Julie Appleby from Kaiser Family Foundation. She has been a guest several times. The only reason why she keeps coming back is because she's writing great articles. So we really are happy, very fortunate and happy to have her on the show. And the topic she has is the ranks of Obamacare fixers axed in Trump's reduction of health agency workforce. This is an article she wrote on April 22nd, 2025, that was placed on the website. I recommend you go there at kffhealthnews.org and then look at her. And one of the things that she is really focused on is this whole issue about the Affordable Care Act and how has this been changed? What's going on in the government right now? So welcome, Julie, again. How are you?
Thanks for having me on. I always enjoy chatting with you.
Yes. Well, how did you learn about these cuts? What tell us about? Let's get right to the.
Yeah. Great. Yeah. This is one of a number of stories that my colleagues and I are writing that are following what's going on with some of the staffing and financial cuts under the first 100 days of the Trump administration. And this one looked, as you mentioned, specifically at what are caseworkers. These are people who are specially trained to help resolve issues that people might encounter when they enroll in or use Affordable Care Act plans, which are also called Obamacare plans. Some people call them Obamacare plans. Anyway, these caseworkers work in a government division that most people have never heard of. Okay, it's called the Exchange Customer Solutions Group, and it's part of the Centers for Medicare and Medicaid Services, which itself falls under the umbrella of the Department of Health and Human Services. So, wow, that's a lot of names, right? But I found that as sort of part of this broader effort to cut staffing in government agencies, that the Trump administration had cut the ranks of these caseworkers. They cut 2 of what were 6 divisions of caseworkers. And in total, it may only affect 25 or 30 people, but this story was just looking at what role do these people play and what might it mean for people who use the Affordable Care Act, that these 2 divisions were basically removed.
Oh boy, yeah, because that was really interesting because we don't know what we don't know, right? If we don't know that this exists, then we don't know the things that are being done on our behalf in the background, and why these workers are so essential to ensuring that we still have access to healthcare. And so, tell us more about the work these folks do. What does it involve?
Yeah. And it's understandable that people don't know about this organization because, most people probably don't have a problem with a plan. It's only if you had a problem that you might even come in contact with, this division within this agency. So I ended up speaking with 2 workers, one of whom was let go in February as part of the wave of dismissals of government workers who were still in their probationary periods, meaning they were sort of more recent hires. And our second worker was let go as part of a broader reduction in force that occurred. It was actually April 1st that the notices started going out. We at KF Health News agreed not to identify them at their request because they fear personal or professional repercussions. So we did not name them. We take that very seriously at KFF Health News. We generally like people to use their names on the record, but we also understand that in some situations, it's not good for the folks to be identified, and they requested that, and we agreed to it. I did get information from them showing that I knew who they were and that they did indeed work for this agency. And then I also confirmed these cuts with a former Centers for Medicare and Medicaid Services top official named Jaffe Grant. He left the government earlier this year and now runs an agency that in part helps former federal workers find new jobs. So we did nail that down, and I did speak with them under those conditions. And they told me a little bit about what the work is that they do. And it's it's fairly complex. As I described them in the story, they're the fixers. They're the ones that come in when enrollees have a problem with their coverage, like maybe a newborn was incorrectly left off a policy, or maybe somebody's contact information or other ways that they was gotten hold of by a rogue broker, and they were either enrolled or they had their Affordable Care Act plan switched. That kind of problem. Or maybe they got married and somehow their spouse wasn't entered onto their coverage and now they can't get medical care. So it's those kinds of problems, that if left unresolved, they can lead to, large bills, or maybe you can't see your doctor, or you show up at the pharmacy and, you're not covered. And in some cases, there's tax consequences if you have been enrolled, and we can talk about this a little bit later, but if you've been enrolled by an agent without your permission, and perhaps this agent put in an incorrect income amount for you, and perhaps as a result of that income amount, you were given a tax credit to help you buy your Affordable Care Act coverage. But at the end of the day, the IRS, you need to reconcile that with the IRS, and it's suddenly, oh, wow, you owe some money. So sometimes these caseworkers were helping those folks too. But let's just back up. Usually when somebody has a problem with their ACA plan, their first call is to the federal Obamacare marketplace, which currently serves, I think, about 31 states. So the call center themselves can handle some of the sort of like more minor concerns or questions, but anything a little more complicated than that gets kicked up to these caseworkers. And again, this is for the federal exchange. And I'm sorry, there's a lot of complicated factors here, but 19 states and the District of Columbia run their own ACA marketplaces, and that's separate. They have their own workers who handle problems. And so those states are not affected by these cuts, but the ones serving the 31 states that are part of the federal ACA marketplace are the ones that were laid off.
Boy, yeah, that's a tremendous number of people. Also, I mean, because you do have a small workforce to begin with, and yeah.
And yet, the HHS is trying to reduce the workforce. I mean, that's part of their goal here. They say that this reduction in force aims to decrease the number of employees. So at the Department of Health and Human Services, which remember encompasses this agency, as well as a whole bunch of other things that people have heard about, things like the Centers for Disease Control, the FDA, and the Centers for Medicare and Medicaid Services. They want to reduce staffing there from about 82,000 people down to 62,000. So a lot of people with layoffs and a lot of people with voluntary sort of retirements, so to speak. So they're really trying to cut staff, and they're saying part of the goal is to save money, and they estimated that its reduction in force will save about taxpayers about 1.8 billion. But I think those numbers are somewhat in dispute. It kind of depends kind of what you're looking at. So but their aim is to cut staff, save money, and this CMS, which oversees the ACA and other government health programs, will lose about 300 workers, and those 30 caseworkers were part of that 300.
Wow. And part of it too is that there's a significant investment that the government puts into training these people, and so that seems like it's wasted money now, because you're training people for a job and then letting them go.
Yeah, there is definitely a training involved. It's look, this is healthcare, so the rules are complex. That these workers have to understand all these rules, and they're somewhat arcane, and they work for an agency and they're busy, so they do get a lot of training. I spoke with one of these caseworkers who was let go in February, and it was during her probationary period. She had joined CMS in October and then spent 3 months in training. And then just about a month after completing that training, she was, let go. And she remarked that this was pretty ironic, because for her, she had sought stability in a job with the federal government, having experienced a layoff during her private sector career. And so she was really pleased when she got this government job and was looking forward to staying on for a long time. In fact, she had actually taken a pay cut to go there. And she told me, and she said it was okay that I described her this way because I didn't want to let on anything, but she's a military spouse and her husband is about to deploy and they have kids. So they need, both incomes. And so she's now out of a job, but she also strongly believed that she was helping people and was really pleased that she was in this position to do so. And, strongly believes that people should have health insurance and they should have someone helping them out if there's a question or a problem that needs resolving. So yes, she went through a lot of training. The government spent some money on that and she was let go. The other person that I spoke with had been with the agency longer. And so the training issue wasn't like a sudden thing that, oh, we just got through training and now they're gone.
Yeah, what I was upset about too is the issue, and I've heard this issue being raised by a couple of people. But if you leave a job and you're leaving the job for poor performance, that when you try to apply for this, unemployment insurance, unemployment monies, and all that and actually interferes with that. That there are rules that are out there where you don't get covered.
Yeah, that can be a concern. I think I read about that. Some of the layoffs initially of the probationary workers. I think some of them were told, and I'm not sure if that was true in this situation, but other stories I've read, the paperwork or whatever they came with it said that they, weren't up to the standards of working for the federal government. I don't know how all that played out, but that is a concern, I think, for anybody who's losing their job is will they be able to get unemployment after?
Yeah, but when do you think people are going to notice this change? Those people who are going to be affected because the fixers aren't there anymore. And some people may not even be aware they were there, but how will they notice that this change?
Yeah, that's a good question. It could certainly, slow things down. Several of the people I spoke with said that already it could take some time, maybe 2 weeks in some situations to resolve some of these problems. Others could be resolved fairly quickly. It depends on the nature of the problem, but folks expected that it could increase delays in terms of how long it might take to resolve the problems. Because there will be fewer workers. And for the workers themselves, it also means they're going to be handling more cases per day. And some of them are already handling like 30 or 40 cases per shift. And now they need to start, scrambling around to cover for the colleagues that are no longer there. So that's going to be tough. And I think so there may be some, some effects this year if people have a problem. Certainly at tax time, their work increases because suddenly people start getting these notices that, hey, I've got this insurance that maybe they never knew they had, because like I said before, some people were getting enrolled without their knowledge. So tax time can be a busy time. And now we've gotten through tax time now. So through the end of the year might not be that big a deal. But starting next year, the Trump administration has proposed some new requirements for enrolling in the Affordable Care Act for some people that might require additional paperwork or that's a little bit more complexities. Those, because they're complex, may be confusing. That may mean that more mistakes are made, which may in then turn mean there's more calls and more issues sent to these caseworkers. So I think that's a long answer to a short question. I think some results immediately, but maybe going into open enrollment next year, there could be more problems. And remember also, there are other groups that help people during the enrollment process, help people figure out their options, help people figure out, how to enroll. And that can be done by calling the marketplaces directly, either the state or the federal one. They've got people there can help. People sometimes turn to insurance sales brokers, but they also turn to these groups called navigators. And this is a little bit of an aside, but these navigators can help people. There's a lot of plans to choose from and help people kind of sort out the differences between the plans, help them enroll. Some of these navigators can also help when there's a complex problem that needs to be bumped up to one of these caseworkers. So some people turn to these navigator organizations when they have a problem. But the Trump administration has also planned to cut the navigator funding by 90% starting for next year's services. So there'll be fewer of those people to help as well. So I think that there will be, potentially a larger need or even the same need, but fewer people to help with that. And remember, there's 24 million people enrolled this year in the Affordable Care Act. So that's a lot of folks. And most people probably don't have a problem, but 24 million, you're going to have some problems.
Oh, that's right. Right. And it may be someone that's working with you, a coworker, maybe a family member. It may be someone that is going to impact you, whether you realize it or not, on how their life is going to be affected. It might be your child. It might be, your parent. But, with that reduction of, from 82,000 to 62,000 is projected, they're going to actually hit the CDC, the FDA, NIH, and CMS. We always talk about, they say, well, we're going to save taxpayers about $1.8 billion a year, but very little is being said about what we're losing. So how is that going to affect us? And is it going to be more costly in the long run because people don't have the adequate health care that they need, or they walk away from these situations and wait to end up in an emergency room somewhere from a heart attack or a stroke or, those kinds of things, while having adequate care. So it's really a very, very complex situation, environment. But, so there was one thing you were mentioning also is about, the people who are out there who are rogues, who are, the rogue brokers that, really are doing a number on everyone by, mismatching them with, and switching them from one program to another. And the people are, there was like a case where he had a newborn incorrectly left off a policy, where discovering that, they signed them up for switch their plan without consent. And then this actually leaves people in a lurch, and without anyone to turn to, you also lose that coverage potentially for life-saving drugs that you take, your blood pressure medication, or, a blood thinner if you're, going through a particular procedure, or chemotherapeutic agent, for cancer. And that is really incredibly difficult. So these fixers, it sounds like, really play an essential role in the healthcare marketplace.
There's a lot of people who are playing essential roles, and they are among them. And as you mentioned, there's been a number of things going on. You touched on some of the stories I wrote a lot of these last year, but just to sort of recap, there were a growing number of complaints last year. It started the year before, it started picking up, but that people were having their plans switched by agents who wanted the commission. So they were stealing clients from other people, some without their consent in some cases, and changing them from one plan to another. And as you know, you've got a health plan, it usually has some kind of network, right? It go to these doctors, this hospital. So if you're switched to a different plan, it might be a whole different set of doctors. So some people only found out when they went to the doctor and found out, hey, your plan doesn't cover this doctor. So that's a problem. And as I mentioned before about the tax situation, some people might have been signed up for coverage they didn't know they had. So this was ongoing. I think there were at least 274,000 complaints about this to CMS last year through August. Now, the number of complaints has gone down. The Biden administration did take some steps to require some additional phone calling, three-way calls with when certain changes are going to be made. Get the client on the phone, get the agent on the phone, get the marketplace on the phone to make certain changes. So that they did a little bit more investigation. So the number of complaints have slowed down, but agents are telling me they're still hearing about some of this stuff. So these are the kind of problems, again, that go back to what we were talking about with these caseworkers, that at the end of the day, they might be helping people sort out some of this. And by sorting out, in some cases, they have to go back and cancel the plans that people were signed up for and get them in the plans they wanted to be in, right? That's one thing. Or in the case of one gentleman I wrote about, he didn't need any coverage. He had coverage through his job. So he was signed up he lived in North Carolina and was signed up by a broker he'd never met in Florida. And he was signed up, they set his income at a level that he would get a plan with no monthly premium, so he never got a bill. But he did get a tax bill because the plan came with a subsidy that was paid directly to the insurer, and he had to owe that back. But what they did, he eventually went to the he went through a navigator, but got to a caseworker with this group that was that I wrote about for this story, and the caseworkers eventually helped him sort it out. They had to go back to the insurer and get them to cancel all the claims that have been used on his plan, because unbeknownst to him, the plan was actually linked to his pharmacy, and every time they filled a prescription for their newborn, it was counting as a claim. So even though they didn't were using this plan, it had automatically switched them to the new plan. Anyway, it was very complicated. They eventually got it all sorted out. He got his money back, taxes, but it took them most of the year to get it sorted out. So that's the kind of things these caseworkers work with, but they also work with more routine things, like you mentioned. One of the last problems handled by one of the caseworkers that I spoke with involved a child born in November who was not sort of added correctly to the family's plan for 2024, meaning that any care the child received during those last 2 months of the year wouldn't be covered, and the family risked sort of being stuck with those bills. And this caseworker told me, hey, this person did everything right, including they called the marketplace within 60 days to report the birth and to add the newborn to the coverage, but the marketplace messed up and they didn't do it right. And so the worker was able to sort of quickly resolve that one because it was a marketplace error. The marketplace made a mistake. This caseworker fixed it. The baby's coverage is retroactively added. The family's okay. So that's sort of like the routine things that these caseworkers might be dealing with, which are not routine if it happens to your family, but they can be sorted out relatively quickly.
Yeah, because there was one thing with the it was the Inflation Reduction Act of 2022 where there was an extension of coverage with the ACA, that Biden had expanded that a little bit. I think that was pulled away, under the current administration. But what I was hearing, it may have some impacts on this too, on the whole situation.
The enhanced, those are the enhanced premium subsidies, and that is going to be a big deal. Congress is going to be wrestling with that this year. These were additional. These were subsidies that gave people on both ends of the income scale additional help. So a little bit more money in some cases on the lower end. And then they got rid of this cliff. Like it used to be, if you were at 400% of poverty, that level, 4 times the poverty level, bam, there was no subsidies available after that. But now it's more of a sliding scale up until you have to spend, I think, 8.5% of your income. But you pay a certain amount, but then subsidies kick in and there's not this cliff at 400%. Those have helped lower premiums for some people in such a way that some people don't have a monthly premium at all, and others are paying smaller amounts. Now, that is also costing taxpayers a lot of money. And so the Congress is now looking to make cuts. They've also got the big tax cut that President Trump put in place in his first term that they want to extend, so that they've got to find some savings for that. So they're going to be talking about all these things, but the enhanced premium subsidies also have to be renewed because they expire at the end of the year. And if they aren't renewed, people's premiums are going to go up a lot. So this is going to become a very political discussion because a lot of folks get these subsidies in all states, red districts, blue districts, independent districts, whatever. So that's going to be a discussion that I think the lawmakers are going to be having about whether to continue these larger subsidies, whether to scale them back a little bit, whether to let them expire entirely. And that's going to be quite a debate. Like you mentioned, that's going to be part of this whole Affordable Care Act debate, and will affect people not this year. People are not going to, the subsidies are not going to change this year. If you've got an Affordable Care Act plan now, you've got a subsidy, it's going to stay, unless your own income changes, okay, but it's going to stay at the level you have. But next year could be a whole different ballgame depending on what happens with these enhanced premium subsidies.
Yeah, because I heard it was like something like about 8.5%, I believe, and it may double if they.
Some people may see substantial increases in their premiums. I think I'm trying to remember. the 70 or 80% jumps out at me. I think there's been some
That's
studies.
Yeah.
A lot of, yeah, it could be a lot higher without these subsidies.
Yeah, and that really has really implications for the health of the people, the clients, the people who are actually being covered. But what do you see? And this is like a speculative question, I think. We've seen people being cut from different agencies, like the National Weather Service, the Nuclear Regulatory Commission. Do you see a point where they pull some people back potentially, and they feel that fixers may be needed? They were essential, to having things done.
Well, I think we've already heard in a couple of cases where HHS Secretary Robert JFK Jr. has said, RFK Jr. I'm sorry,
RK, I know. Yeah.
Has said that maybe they did lay too many people off, and they're going to retroactive. What jumps to mind is the childhood-led program that appeared to be eliminated, but I think in later reporting, he said that they are going to restore some of that. But there's been a lot of, if you just look at some health-related budget cuts, there's been a lot. So, and there's a real goal of this administration to reduce federal workforce and federal spending. So I don't know how much they're going to put back. Right now, we're just trying to still figure out what is getting cut and what are some of the changes and what's behind the scenes. One of my colleagues, Stephanie Armour, wrote an interesting piece this week that looked at some of the health programs that are being trimmed. And so she found that there's been like billions in funding for indirect costs associated with health research, including studies into treatment for Alzheimer's and cancer. The government also wants to trim $880 billion from its expenses, and a lot of that would come out of Medicaid, which is the program for federal and state. It's a federal state program to cover low income people. But there's been other programs that have been cut entirely. Like I believe the CDC's Office on Smoking and Health was eliminated, and that office worked to protect people from tobacco use and prevention, that kind of thing. So I think we don't really know yet if there's going to be sort of a rollback as they start to see, hey, maybe these cuts are affecting folks, and we'll restore it.
Welcome to AHG.
Yes, hopefully. Yeah. Okay. Well, thank you so much, Julie. Like I said, people need to read your original article. You are an incredible writer, and I learned so much from your articles every time I read them. So thank you for the work you do, because it's protecting our nation too. So as a veteran, I thank you for your service.
Thank you for having me on your show. Appreciate it.
Okay. Take care.
Okay.
Okay.
Welcome to AHG Connects, where voices, information, and resources are empowered intentionally. Where voices, information, and resources are empowered intentionally. Market, advertise, and sponsor your business with Vietnam veteran Cliff Kelly and America's Heroes Group, where information and resources are intentionally disseminated via radio, print, and social media. Call our office for more details at 312-803-2618.
Ken Jennings. All of us here at Jeopardy want to thank you for your service to our nation. We truly honor and appreciate you, and what's more, we're looking for contestants like you to play on our show. So head to Jeopardy.com now and take the Anytime test, and we're looking forward to seeing you soon right here on the Alex Trebek stage.
intentionally.
Good evening. Welcome to America's Heroes Group Roundtable live stream digital media show. I'm your host, U.S. Army Combat Medic and Flight Surgeon Colonel Dr. Damon Arnold, U.S. Army National Guard, retired. Friday, May 9th is Military Spouse Appreciation Day, which recognizes the service and sacrifices of military spouses. Make sure to reach out to them and tell them that you care about what they do for us. Also, it is Mother's Day coming up on Sunday, so happy Mother's Day to all the mothers out there, whether they are your children, natural children, or whether you have adopted the rest of these kids around you and have given them a better life just because of your presence and what you do for them. We have a guest speaker today, Carolina Stewart, and she is a home health nurse coordinator at the Jesse Brown VA Medical Center. And we may also have Adelina Marshall joining us as well. She is a mental health nurse at the VA. But today we're going to have a topic, National Nurses Organizing Committee, National Nurses United. And the nation's Nurses Organizing Committee and National Nurses United represent more than 2,000 nurses at Chicago VA facilities. And the director, Adelina Marshall, who also works as a nurse at Jesse Brown VA Medical Center, was among the many voices who were talking about these mass layoffs, as well as Carolina Stewart. They both have been instrumental in making sure that the alarm bells ring a bit about what is going on at the VA as far as staffing issues. Hello, Carolina. How are you doing?
I'm doing well. Thank you, Mr. Arnold, for having me today.
Oh, absolutely. Yeah, I know you're working around the clock as usual. The nurses at the VA system should be paid in gold, every week, and in a weight in gold. How about that? But really do quite a bit of work for our veterans and go far beyond the call of duty. Sometimes working extra hours, which are sometimes not even paid for because you just have the commitment to take care of veterans. You care so much about us. Mm-hmm. So, yeah, tell me, so what's going on recently about this whole staffing issue? I know there's so many rumblings going on in the administration in Washington, D.C., and it's affecting a myriad of programs right now. But how do you see this affecting you right now?
Well, it as a nurse, it absolutely it affects our ability to provide safe and efficient care to our veterans. One of the biggest rumors right now, the biggest myths, is that there is a nursing shortage, and it's far from being a nursing shortage because there, in every state, there is a number of licensed professional nurses that are able and ready to work. However, the working conditions, the working environment, it's not pulling the nurses in to be able to securely feel capable in being able to provide the services. So it's not a nursing shortage. It's just the working conditions that some of management and leadership, they're not willing or able at this time to see the benefit in providing for the nurses.
Oh, wow. Okay. That's a different twist on it, because usually when we hear things, we think about staffing shortages and, it's more, we can't find anybody, right? Rather than.
Exactly.
Interesting. So tell me, what are some of the things that are going on that you think need to be addressed?
Well, one of the biggest things right now is the executive order within the reduction in force action that is affecting all government agencies, not just the VA, but it is also affecting the VA. And in that reduction in force, in which they're looking to reduce the workload by over 80,000 employees, which could include nurses, that in itself is going to add on to this quote unquote shortage. So again, it's not that there are not nurses, there are not clinicians able and ready to work. They're taking away from that staffing by, again, not staffing enough nurses to be able to securely have a good nurse to patient ratio. They're not making sure that there is safe environment.
Yeah. So what is the ratio now? How is it the nurse to patient ratio and the hours you work and that type of thing? Maybe you can describe it, a typical day. Carolina?
I'm sorry. Yes, I'm still here.
Oh, you're still there. Okay.
Sorry, it seems like I have poor connection today.
Oh, okay, sure.
But yes, and just again, just speaking to that reduction in force, it's taking away from the staffing, not only from the nursing, but from the ancillary staff. These are the members of an interdisciplinary team that helps, whether it's dietitian to bring food, whether that's the EMS or the people who help to clean up the rooms and things like that. When they reduce the force and even the ancillary staff, that takes away from the nurse's ability to provide bedside care. And now the nurses are having to also take on other duties of other disciplines. So all in all, it takes away from the nurse's ability to be able to perform their true task.
Yeah. I was a resident at Cook County Hospital. I remember I was a medical resident, a transporter,
Right.
a pharmacy tech. I mean,
many hats.
Many hats that you get pushed into. But that really should not be the case, because what it does is it takes away from your ability to provide direct care, I imagine, as a nurse.
Correct.
Yeah. Here we go. Adelina, how are you doing?
I'm good. How are you?
Good. I mean, the last time we were taking a walk down next to the VA. But yeah, we were just talking about, the challenges that are facing, the VA nurses, and some of the things that you're facing now, with the new administration coming in as well, that they may have different effects, or they need to be aware of certain things that you are aware of that maybe they can try to help or modify. But Carolina was just telling me one thing that was really interesting, was that it's really not an issue of not having enough nurses. It's having the kind of proper work conditions and that will attract people to work in that environment. People will try to gravitate towards systems where they make more money or have better working conditions. That's a natural tendency in the whole market system. But what are some of the things you see, in the setting, like how many hours that is a nurse required to work, or, what are some of the things that you feel that nurses are confronting because of the way things are being managed now?
Well, some of our problems now is we're seeing a little bit more aggression from management towards the nurses. It is Nurses Week, and
yeah, Happy Nurses Week as well.
Thank you. And they sent out congratulations, but yet they're taking the nurses, taking things away from the nurses that were bargained for, such as 72 for 80. And as nurses are leaving, they're very limited as to recruitment. So we just had a few new nurses the other day that was in orientation, and I was told they had not quit their prior job. They just took a leave or vacation because they don't know if they'll have a job tomorrow or not. They're considering, or we have been told that there is going to be a RIF, which means involuntary
reduction in force. Yeah.
And so day to day, we don't know when we get up if we'll have a job or not. And we are essential workforce, hard to recruit. I don't know how we were going to recruit people looking for jobs. They will probably not want to seek jobs out at the VA or federal sector, the way things are going. I feel like it's an attack on the good men and women and our veterans who have sought to work in the federal sector. Pay is often 10 to 20% below market.
Right.
The benefits are equaling out to private sector. So our middle seniority staff are the ones that are greatest risk because they have a lot invested in the VA towards retirement. The junior staff can leave and they're much more, adaptable. And then the more senior staff can retire. There'll be an exit. We have one nurse that left. She had 7 years approximately. And she stated that she doesn't even ever want to go back into nursing anymore because of the uncertainty now related to the job that she once had. Mm. So we had today, they celebrated 3 of our centennial veterans. They're 100 and I think one was 102 and 103. And they stated that they felt strongly that they're alive today because of the VA. So they're complimenting the care that they had received and the attachment they had to the staff, because many of our veterans, we've known them through the years of their care at the VA, and this is for all VAs. And so they become attached to the staff as well as the staff becoming attached to the veterans.
Yeah, and there is almost like a family feeling when I go to the VA, and I go to Jesse Brown, and it has improved leaps and bounds since I was back in medical school, back in the dinosaur age. That's back in the 1980s. But I got to the point where I really appreciate the things that are happening for veterans and the kind of care they're getting, and they feel comfortable with it. And I'm not sure going to the private sector, because there's always that thing lurking in the background about privatization, of the VA, and trying to move away from that. But it's kind of an interesting story. But when I was a medical director, I was running the Illinois Department of Public Health from 2007 to 11. I went on a talk. I had to give a talk in Taiwan. So when I went there, they have an incredible medical system, right, where everything is electronic, and everything is done on a card. You never see a piece of paper as a patient. You never see a bill, right? And the way that they ran their system, I asked the person who actually was making the system, who was a medical director of public health, and I said, "How did you put this thing together?" And he said, "Well, what I did was I, looked at the way that your VA system works in the United States. And I also looked at the VA and the Medicare system and how they function as far as their functionality." And I said, "Well, how do you get these computers to do everything?" Because everything was by image. When you walked in as a patient, you never had to, you just had ID numbers that you exchanged with the provider. All of your medical records since you were a child come to that person's desk. And I said, "How did you?" And he said, "Well, we make the microchip." So they built their system, the microchips and their computer systems to meet the needs based on what the VA was doing in this country. And so it's really amazing to me that we don't realize the efficiency and the resiliency of a VA system, and that model, which other countries are really an envy of and are sort of modeling themselves after.
Yeah, there is a system currently like the VA, and it is a model for other healthcare. We are very proud that we are federal VA nurses. A lot of times the public doesn't realize that we are federal employees, and many of our employees are veterans. Our nurses, our doctors, our housekeepers, our food service, our lab personnel, they're all veterans and highly professional and highly dedicated to caring for other veterans.
Yeah, that's a very important point, because about 30% of the federal workforce are veterans, nationally. And out of that 30%, they say about 15% of the 30% or approximately half of them, are people who are disabled veterans as well. So some of these veterans who are working actually went to things like the Volks program that actually is part of the VA system. And they got training and specialized training for disabilities so that they could actually still contribute to the country and not go on welfare or go on some other way of, living, or,
Right.
End up on the street. And to get rid of these veterans is actually, it's immoral to me.
Well, the veterans who working for service on and on, they now lose their private health care and have to seek care, or will probably seek care through the VA. And then if they have all cuts, the staff is not going to be able to serve, or the VA is not going to be able to serve that many more people who are influxing into the VA. They won't have private insurance. So now Obamacare, they'll probably seek out insurance coverage through Obamacare. So I find it very ironic that does not appear to be consideration for our veterans and the private sector and how they're going to get care. Because if they lose their private insurance coverage by being discharged from the federal government, then those who are veterans will end up turning to the VA. And if they end up laying off some that is already short staffed, it's just going to be a tragedy.
That is, yeah. That's really a deep consideration. I'm hoping people are paying attention to that as we're going forward. Also, one of the things too is that you have people who actually have been exposed to different things like Agent Orange for Vietnam veterans, like the burn pits for people who are in Operation Iraqi Freedom, Enduring Freedom, and a lot of their medical records are tied up into the VA system, and they are actually being processed. People are being evaluated for those conditions, and in a general practice, people may not be aware of what is needed. So, a primary care provider may not know what tests to order, what to look for, how to interpret, a lung scan, or those things that you need that kind of specialized care where you have a coordinated team of VA doctors who deal with that all the time and understand how to interpret things. So it's really kind of, it can also mean less of a level of, acute care directed at a veteran by someone who understands what they have gone through. And the same thing with nurses, taking care of patients. If you've taken care of someone in the general population, there are other considerations. Like I know you, because of your background with mental health nursing, many veterans have PTSD and other things that are going on that may be very idiosyncratic that people don't realize in the general population of people who are providing care, and they may have their own biased opinions about what a veteran is and that kind of thing. So what do you say about those things, where the services that are being provided within the VA walls are very specialized and very focused on veterans?
Carolina, do you say anything?
Yes. And I mean, Dr. Arnold, you hit it right on the head. The VA, we have nurses and different professionals that are skilled in the specialized needs of our veterans. As you mentioned, there are a lot of ailments that veterans, occur while, active duty and thereafter. And we have grown to learn how to identify veterans' needs and how to treat them, and understanding that all issues are not acute issues, and that it does take, time and consistency to be able to see them through. For myself, within community care, we work very hard with our veterans while they're inpatient, before they go home, to make sure that they have all of the needs that they require to manage their health care at home, whether that is a home nurse who can visit once a week just to ensure that their medications are being managed correctly throughout the week, or whether that's physical therapy or identifying that they need someone to help with household chores that may better be able to assist with some of their mental conditions. So it will affect our veterans, and we will likely see higher hospital admissions and readmissions because they're being sent home without the proper treatment to be able to manage their health care at home.
Ah, yes. Yeah, that's a good point. And, when I was, a resident over at Cook County Hospital, I I was doing internal medicine. So I did internal medicine and then second residency in occupational environmental medicine. So I did 2 residencies. But when I was doing that, when people were coming through the emergency department, we were asking them whether they were veterans, and we knew that they would get great care over at the VA. So we would be directly in contact from the emergency department with, the emergency department at the VA and talk to them about, getting a veteran over so that they can get their care. And that was something that we knew that we were sending them to a higher level of standard or a better avenue for them to receive the proper care that they needed.
Mm-hmm.
Well, I was just talking to someone the other day, and she was telling me that her husband seems to be very grateful without provocation.
Mm-hmm. Mm-hmm. Oh, Adelina? Mm-hmm. Hi, Carolina.
Hey there.
Adelina was having problems, technical difficulty.
Yeah, I see.
Yeah, she was okay. Yeah, but yeah, that's one of the things that we were just talking about, how the type of care that's delivered to veterans is actually better managed by the team there. I know that veterans, when I speak to them, at least in my Veterans of Foreign War Post and the American Legion Post, that veterans feel very good about the VA system. They feel
Yes.
comfortable with going there and seeking care. And they feel like people care about them, and that they're not just pushed aside or looked upon as being, a thorn in the side of the medical care system, right?
Right.
And
And
go ahead.
I'm sorry. And I think one of the things, as you mentioned earlier, it's a family. So even
Yeah.
though a veteran might be dealing with one issue, before they're done within that department, let's say they just go to a basic appointment, they talk to people and they learn about so many different resources almost every visit. When I spoke with a veteran before, I was able to give him information about Meals on Wheels and even transportation, things that weren't even part of our discussion. But because we take the time to listen and we, try to help guide the conversation to really see what it is that the veteran could benefit from, we really come to find different, resources and things that are available to them that they didn't even know about. And that we're able to connect them with to, kind of cover their overall plan of care. So I think that's one thing about the VA. Even though every person is within their specific department, we always look into how we can connect the veteran to optimize the max of their benefits.
Oh, that's fantastic. And as you were saying that, I was thinking also that, the veterans need to be cognizant of what's going on over there too. and I'm not sure if there's something that veterans can do, write their congressional members, talk to somebody about the needs that are going on within the VA system. As far as the nurses and the staffing issues that you're talking about, it sounds like some of it's just trying to figure out the logistics about getting things done and having the right working environment for nurses to function within. But any success stories that you have for where you think that that being in the VA system actually played a positive role in making sure that a veteran was taken care of adequately.
Absolutely. And I mean, just to piggyback off of Miss Marshall, Adelina's comment about us celebrating our 3 centennials, they are a prime example, and their words in themselves to show how they have been able to receive the proper care, the care that they feel like they have been able to benefit from throughout their years, many years of the VA. And I'm sure throughout the time, they've come across so many different nurses, so many different professional staff. So that's to show even the evolution of, healthcare within the VA system. We're steadily growing. There, wasn't a moment, it seemed like, with those centennials where they felt like someone dropped the ball. They were able to speak of, high standards with the VA. And that is another reason why, we take the time to celebrate our centennials, because they have absolutely reached a milestone, and they have, walked the journey and have allowed us to walk the journey of their healthcare with them. So I think that in itself is a huge success story. And again, it just speaks to the evolution of healthcare within the VA and more reasons why we need to pour into it and not take away from it.
Wow, that's a very, very good, excellent statement. And I could feel myself walking back down the halls of VA and getting care. People were taking care of me.
Yeah, and they would greet you with a smiling face.
Sure. Yes, ma'am. That was something that I really loved about the VA, and it was always a sense of care and compassion. And we're running out of time. They're playing my music in the background. But Carolina, Stewart, we have got to get you back on. And it's Adelina, Marshall, we will have you back on too. But thank you for your fight, and thank you for what you're doing for veterans by pushing this issue forward.
Thank you, Dr. Arnold. It's always a pleasure. I would love to be welcome back. And I truly appreciate you getting the word out and just bringing awareness to, a lot of the issues that we face.
Okay. Take care.
Thank you. You as well. Bye-bye.
Bye.
Where voices, information, and resources are empowered intentionally. Market, advertise, and sponsor your business with Vietnam veteran Cliff Kelly and America's Heroes Group, where information and resources are intentionally disseminated via radio, print, and social media. Call our office for more details at 312-803-2618.
Ken Jennings. All of us here at Jeopardy want to thank you for your service to our nation. We truly honor and appreciate you, and what's more, we're looking for contestants like you to play on our show. So head to Jeopardy.com now and take the Anytime test, and we're looking forward to seeing you soon right here on the Alex Trebek stage.
Intentionally.
Hey everyone, Jer Wellman here with Overwatch Capital. Waiting for my colleagues Rob Howard and Rod Matthews to join. We're going to be talking today about green energy, waste energy, community choice aggregation, and the political economy coming to your local utilities, your local procurement of energy. So, as a veteran myself, spent 8 years in the U.S. Submarine Force out of Norfolk, Virginia, operating nuclear power plants. That was when I wanted to get into energy way back when in 2000 to 2008. Saw what Enron was doing to the state of California, where I'm from, way back in the 90s while working at McDonald's in high school, and kind of realized need to get into energy and try to solve these energy constraints that we're all suffering from. As you might see on your local personal utility bills, the cost of energy goes up year over year. The good news is, with the right level of advocacy and participation in decarbonization, there's a good pathway here for us to start to create some cost predictability with respect to using intermittent renewables such as wind and solar. One of those particular pathways is through community choice aggregation. Now we're seeing it in some states. We're seeing it certainly in the West Coast, California, Oregon, and Washington. We're also starting to see it in Illinois, some parts of Wisconsin, and also on the eastern coast, basically Maryland all the way up through Maine. And what is a CCA? I think that's a really good question. The simplest way to think of a CCA, the title stands for Community Choice Aggregation, fancy term for saying we're going to go buy solar and wind power in bulk through a public entity set up under the same rules as a special district or joint power authority, like what you would have at a port authority, like the New York and New Jersey Port Authority. Same thing with Los Angeles ports, or also wastewater and water districts at times will use the same structure. So the same municipal public legislation and code is then used to set up basically a public procurement utility. So sometimes you might see people come to your house asking you to sign up for different solar plans, different things along those lines. And this is in essence the public sector, nonprofits taking over the procurement of energy and then directing it to the customers, to the clients. So there's good news here. There is a pathway here to choose to go green with respect to wind and solar, and also battery storage and even biomass, and help push the procurement away from just the utilities into the public sphere. So we've got Rod Matthews here joining us. Rod, are you there?
We are.
Oh, there he is.
Great to see
Rod.
you.
Hey, good to see you.
How was everything?
So pretty good, giving the audience a little bit of an update on all things decarbonized electricity, certainly from the CCA view, spanning solar, batteries, wind, and biomass. Some of the stuff that you and I love to talk about offline, but here we are online talking about it. So, lots of good news in the space, depending upon certain locations across the country, certain states, certain counties, certain cities, bringing forth the opportunity to procure this decarbonized energy to help bring inflationary protections. Since one of the big benefits of this energy is that it doesn't consume traditional fuel. So, the usual price ratcheting of, say, natural gas, coal, diesel, other fuel sources is not present in this particular electrical realm, and that's a big benefit. So do you have any thoughts on the CCAs and how these different types of energy, including biomass, play?
I think it's a wonderful thing. I think it's something that more states really need to adopt. Here in California, we're used to the CCA concept, but in Chicago, in the Chicagoland area, they have a lot of different types of CCAs. Chicago has its own, municipal CCA. You have some collectives in the area. Either way, they're all, they have mandates to, make the fuel that we consume be, less carbon efficient, be more carbon efficient, and decarbonize all of these things. Most of them have microgrid projects, infrastructure projects in the works. So it's very exciting.
Yeah, agreed. Hey, Rob Howard, you there? Can you hear us?
Yeah, I can. And again, apologize, you guys.
Well, we can see you, but we can't really hear you, Rob. But your Mr. CCA is now engaged and online, so we're gonna leave it to the expert, the maestro himself.
All right. Is that better?
There you go.
Absolutely.
Yeah,
We can
that's
hear you
better.
better now. Thank you, sir.
Oh, okay. Yeah. It's the CCA world is the wild wild west right now. So I'm pretty excited about this. Apologize for being late. We were literally in a meeting discussing how to actually move some projects and didn't get out till late. And of course, it's the day for traffic. So thank you guys
Yeah.
for sitting in. That the partnerships that you all create, that's what makes it work. So thank you again, man, for you guys being there.
Absolutely.
Exciting. It's always good to chew the fat, and help share the message outside of us, chit chatting like the good old days in the Navy, BSing and having a good time. It's nice to spread the message and share it with others and say, hey, look, there's the good news out there that, as things get more and more expensive, alternative energy gets cheaper and cheaper. And the more that we scale alternative energy through procurement through the CCAs, the more that we decarbonize and the more we deliver cost predictability uh, to everyone. And we got to figure out on a legislative side, policy side, how to spread the message about CCAs to other parts of the United States as well. Do you guys have any
Well,
thoughts on how to do that?
Yeah, there are several states that are having under consideration right now. There are 8 states that have gone CCAs. There are like 3 more states that are considering right now that actually have some ballot initiatives behind it. I think eventually to aid in the transition of our entire grid system, it's going to really take initiatives like CCA initiatives to push this decarbonization.
and I think one of the things that it's hard when you don't deal with legislation to recognize that it's a slow moving. I connect it to like dinosaurs. It's like you step on a dinosaur's tail, it'll be a while before that dinosaur feels the pain. And so with legislation, particularly around CCAs, because I noticed looking at the ones in Illinois, there are some very aggressive goals. And when those goals are that aggressive, at some point you have to have that layered approach where you get the government support, you've got capital coming in from individual businesses, but what we don't want to do is forget that in order to make this transition work, we have to include those folks who just can't afford it. So we have to figure out how to include them. So things like community solar, where you've got solar, battery storage, other renewable options, where the profits from that roll into the community with lower bills, with cleaner air. You have to have a all of the above approach, or it just I don't see it working. I don't know. You guys can let me know what you think, but it has to be a group project, not just an individual, either government or business trying to make money. You need government, business, and the community.
So there has to be strategy around this, and it has to be looked at from a partnership collective. Have, like we talk about all the time, those public-private partnerships are really what's going to enable this. We talk about the 3 Ps all the time.
Guys, along those lines of how to kind of make it more, I guess, whet people's appetite for this particular process, where there are ways here to deploy decarbonized solutions in this mosaic of wind and batteries and solar and biogas, biomass together. You've got to capture the resource when it's available. You got to store it for when it's needed, and other particular resources like biomass and biogas. There's a 24-hour day production for those particular types of decarbonized methane from wastewater plants, landfills, dairies, chicken farms, gasification projects of solid waste. So there's kind of this full circle of integrating these together to not only decarbonize, but also to open up environmental remediation opportunities. And the good news is, with the advent of data centers and additional energy demand on the grid, those particular clients like AWS, Microsoft, a few other firms that I'm talking to, they're looking in the long run at an apolitical energy procurement strategy So municipalities and local activism can get these CCAs ready to start contributing and selling electricity to the data center industry, which benefits the local special districts. At locals, it brings the cost down for the ratepayers that would then get this stuff organized and put in motion at the political level. And even if you think about it, you could end up having certain financing packages where through certain relationships, you can deploy these projects, and in 10 to 20 years, once the projects are paid off, the infrastructure is still valuable, and it then gets reverted back to the special district or the municipality or the county, and then it's owned by the citizens themselves. It can help defray, can generate money for the general fund or for special funds at the political administrative level, and also continue to pay for other projects into the future. So there's kind of a revenue stream potential here that is usually not possible in most traditional procurement ideas or concepts with respect to municipalities, counties, special districts, etc.
So, so JR, the one thing that keeps coming up in discussions we've been having through the expansion really has to do with, it looks like these community choice aggregators are just in the urban areas because, oh, these are the folks who can get it done. But I've seen recently there's an expansion into the rural areas because of the affordability question. But also, can you touch on, if I go to the more urban areas, what resources do they have available to inject sources into the energy life cycle of, let's say, microgrids in the rural area? What's available there that people may think is trash and
Mm-hmm.
won't recognize that something is possible to be used as a source?
Well, Rob, that's a great question. So I think of it like this. If you think of the countryside, the farm areas, the ag areas, they have lots of space, and the space works really well for collecting wind and solar energy. You can also put in that space some battery storage to help capture the energy, then deploy it when it's needed on the grid through the transmission lines. We see that here in California with respect to CCA procurement, where as long as you're within a certain ISO area, which is a fancy name for a portion of, say, the California electric grid, a grid within the grid, as long as you're in that particular zone, then it's easy to then produce and send the electricity to the end users, say in the more urban or suburban areas, as Rob said. I like to describe this by, if you ever remember when you were a little kid, or you take your kids to the restaurant and they're getting served like a Jolly Roger or a Shirley Temple, they always bring out from the bar when they're little kids, little tiny stir straws. And when your little kid is trying to drink the drink, it's okay. But then when you're 8, 10, 12 years old, you want to upgrade to the big straw. Well, some of the things that we've got here in some of these electric grids, we're drinking from straws that are a little too small at certain times of day to let the maximum amount of electrons flow from the resource to the consumer. So Rob, to your point, even if you don't have a lot of surface area for wind or solar to produce energy, the good news is on the times a day where the grid has better availability and capacity to flow the electrons the same way that you would consume soda through the straw, you can then preferentially consume the energy through electricity, store it locally in the urban suburban areas with battery storage. Because when you have a connection to the grid, whether it's on the upside, the production, or the downstream consumption, either way, you can store the electricity. So then you can, what we call, at least when I'm talking to people, I like to say we can shotgun electricity the way that we shotgunned beer, during port calls in the Navy, where, you might not drink it all the time, but when you drink it nice and quick and nice and fast. The beauty of it, Rob, is that with the right sequencing here of battery storage, where you position it to then absorb the intermittent renewables, 16 to 18 hours a day when it's available. And then those batteries augment the grid for the 5 or 6 hours a day where the transmission has a constraint. That's how you buffer. That's how you shotgun the electricity, like we shotgun beer. So I figured with the veterans online here, veterans, sports people, and there's a certain frat boys, sports people, and military vets. We typically have a clue about periodic overconsumption of beer, which we're trying to do that with electrons here. So, anyways, that's my best analogy. I'm sticking to it.
I know one of the things you said, about that rural area is what some people think is trash. And literally, trash is what can power a lot of this stuff. This is what we think is trash. It's biomass, these farm areas. There are all kinds of things that can be used as feedstock to run these biomass production facilities. And also, there are tremendous opportunities to do some behind the meter projects to really reduce the overall demand. By servicing behind the meter, so to keep that demand off the grid. So I think with the combination of those two objectives, we can really see some improvements as well.
And I like to go right to savings, because I think at the end of the day, the transition is happening. It's happening right now. But I know for a business in particular, let's say you're doing manufacturing, you're using a lot of power. Two things I like to touch on, particularly with the ag community, that I didn't know how complicated it was about. We were talking to some of the ag customers about when to water, because it makes a difference on the cost of the power to run those pumps. I said, if you're moving water, it costs money. So one, working with the ag community to when to actually use power is a big deal. And at the same time, if you go back and look at what's available from the biomass, what's available from the other fuel and energy sources, where are we with actually, as far as percentages, and you may or may not know this, but when we look at individual states, how far along the line with regard to 100% renewable, if we were to get there? I know in some states there are days when we can use 100% renewable energy for that day during portions of the day, but what are the major, besides storage, items we can use to get that, what I call baseload power, in the off hours when I'm not using solar, and when solar's not available and wind isn't available? What are we looking at? So, because I want to make this real for people to know what's available, how we can get to it, and for those veterans out here who are looking to get into this industry, because honestly, the opportunities are, I think, right now unlimited. What's available besides the solar wind? Because that's what people know about.
Well, so
Either
many
one of you
things.
guys.
But
Yeah.
yeah,
Go ahead, JR.
let me be the leadoff guy for once in this, because I love the waste energy piece. So feedstocks, as Rob mentioned earlier, almost anything could be converted into a fuel. This is something that a lot of people may not quite realize, but whether it's the green waste bin that's now very common in certain parts of the country where your yard clippings and branches go into, anything that's from a tree or a plant or a shrub, it's got cellulose, hemicellulose, and lignin components in there. Those can all be converted into what's traditionally called a biomass process, which is basically heating it up to the point that it starts to combust, and then you extract the heat and steam out of it to run a turbine. That's generally, something that's been around for a long time. We're now seeing adaptations of that technology into gasification units, pyrolysis units, where the temperature is turned up even further than, say, just a traditional biomass plant. So yeah, you chop the stuff up into super fine agricultural waste, kind of like sawdust is kind of the consistency of where these processes want to have the waste input be. So they can take it from the green waste, they can take it from solid waste after, elements of solid waste have been recycled and removed, like metals and stuff would be removed from the waste stream. Plastics can be in there as well. They can do all kinds of stuff. So you turn, solid waste into, from say a stock accumulation of detritus from people's waste activities, then you turn it into a recycling event. Anything that can't be recycled is then put into a gasification unit, pyrolysis unit, or a biomass unit. And you've got here, like in Southern California, Imperial County, and then the Central Valley, high desert areas, there's a number of these facilities that are kind of ranging between 2 to say 25, 30 megawatts. I think the rough thumb rule is for every megawatt, 1,000 kilowatts, it's roughly 500 homes in terms of power capacity that's being supplied. Those numbers might be a little off because it's from a decade ago. You guys might know better,
Mhm.
but just as a nice placeholder, when people say, what's a megawatt? Roughly 500 homes worth of 24/7 energy consumption as electricity. So anything that we can do to take waste that would normally get accumulated in a landfill, we can now divert that and deploy it. And it takes a lot of skill sets that veterans have to keep these plants up and running, to develop them, to do the lobbying, to do instrumentation controls, the financing, and often there's preferential status given for veterans to step forward and take the lead on these projects and contribute. So, Rod, you have any thoughts on that?
Yeah, particularly when it comes to veterans, as you were talking, even in this current climate that doesn't seem as friendly to these type of projects, this work is actually going to keep going. The demand is way too high. The technologies are proven. We know that we can save money, we can decarbonize, which is going to be helpful to our environment. So it's going to happen. And I think the veterans here in this country are really going to lead the charge in this, because we need the skill sets, as JR alluded to earlier, that they possess to really get these projects and make them happen.
I want to follow up on something you said, JR. My environmentalist friends, because they don't understand all of these processes, um, can either of you explain to me how are you able to take that biomass and quote unquote burn it and not pollute? How does that process work so that you are still being environmentally friendly and not polluting when you are literally taking that fuel and burning it?
Well, how much time do we have, Rob? That would be a great
Give,
chat. I can
give.
wax philosophically for days on that subject, but we've got, I think, just 8 minutes left, so I'll try to keep it brief. I guess the 2-minute drill here on how to create uh, clean energy from biogas and biomass. You have to pick and choose the fuel, the feedstock into the process that is the fuel. You've got to prepare that. You've got to apply mechanical and thermal processes to the feedstock. You've got to filter out certain chemical gases and chemical constituents from it. It's always easier to filter out contaminants from a process before it goes into the energy conversion side of things.
Mm-hmm.
So preemptive, filtration, no different than say washing vegetables before you make a salad. Similar kind of concept, just at a physical engineering chemical level, even a biological level for the waste. Then once you get that fuel ready for the energy conversion system, once it's ready to go in, you're going to choose certain types of energy conversion systems that are modern, that are going to have controlled operation with advanced engine management, turbine management, gasification management systems, similar to say the ECU that controls your car and the fuel injection on your engine. Very advanced systems exist now in the power plants. And then on the backside of the process, you're going to have selective catalyst reduction and particulate reduction filtration. They're very similar in theory. They use exhaust heat from the process to then burn up particulates and excess hydrocarbons and fuel, and to reduce NOx formation, nitric oxides, that then create smog and VOCs going into the atmosphere. So you hit it in the front, you clean up in front, and then you clean up on the back end, and then you run the particular energy process in a very precise, controlled manner, similar to how modern engines are. It takes 1,000 modern engines right now of cars to equal one engine from the 1970s in terms of emissions impact. Certainly we see that work its magic here in Southern California versus 20, 30 years ago, where the air was, much, much dirtier than it is now. So that's generally how the big industry is now following the advances made from the smaller automotive engines. It's tracking.
And it's something we don't really have time to really go through right now, but we just touch on briefly. It's like the whole circular economy that opens up, where literally every off-take that there is no waste. Every waste is converted into a usable product. So
And
that's something we can get into a little later.
yeah, and I think probably if those who have engineering backgrounds, just the example I like to use is engineers design to a price point. But in this circular economy, that you're not designing to a price point. You are focused on not having waste, because if you design to a price point, you create waste to get to that price point. So I think really understanding that, and we can probably dive in a lot deeper when we have more time. The other thing that I wanted to touch on is you run those processes. What can I do with the ash that's left over, since we're not creating waste, we're creating products? What do I do with the ash or the final product from that process?
Well, typically now with these advanced clean processes, they're run at high enough temperatures that it separates out hazardous material and eliminates it as part of the process. So you now have clean, say, class A biosolids in the case of, say, a wastewater plant or sludge off of a dairy. That's now becoming a soil augmentation, similar to solid waste. It becomes an ash. It's almost like, the ash left over from a barbecue. If you're using charcoal briquettes, it's just way cleaner, and it turns into a soot. And then it's used often as a soil amendment. It can also be used in industry, potentially as carbon filters for certain applications, or it can be just put into landfills and kind of sop up some of the compounds that exist in landfills, and help the leachate situation out, as the leachate in a landfill can be a bit difficult to manage. So yeah, we would need a few episodes here to go deep dive on those particular realities. And they're going to have to get this podcast up every day for us to go through all this. But happy to do it. Happy to do it whenever we get to that cadence, right, guys?
Yeah.
Well, have to make sure they're really sleepy when they do it as well.
Yeah.
Yeah.
Well,
you'll put me on at 11 o'clock at night. I'll put you all to sleep. It'll be mid-watch.
Put everybody to bed.
Up.
So for the non-farmers, I heard you use the term that soil augmentation. So I'm not a farmer. Did I hear fertilizer out of that? Is that what we're talking about? To be able to, so now I can literally help crops at the same time, that later, once they're done, I've got that crop waste. So I'm back to, Rod, what you talked about, that circular economy.
Absolutely.
Is that what you're talking about, JR?
Yeah, that's exactly right, Rob. It's in essence a waste that uses the carbon that is retained from the process to make an ash, and the carbon itself becomes a substrate to mix within soil. And that really helps augment.
I think the Sandman is getting this.
Yeah, they're playing us out next week, next month, folks. We got Mario Short, who is in the Chicago area with Site Corporation. He's going to talk about what he's doing in that area, and we're going to talk fertilizer a little more with Rod and JR in the next episode. Folks, we thank you for being here, and again, keep focusing on veterans understanding what they need to do, because this new clean energy economy is made just for you. Everybody, guys, I want to thank y'all for coming in and sitting in and taking care of it for me. Thanks, guys.
Good to see you all. Take care, guys. Bye-bye.
All right. Bye.
Where voices, information, and resources are empowered intentionally. Market, advertise, and sponsor your business with Vietnam